co-PI on a recently awarded grant related to quality improvement, and Angie Peden is our project manager for our state coordinating center for the PBRN. Ketty Gonzalez is a district director. Dr. Gonzalez is a district director for one of the districts in Georgia, and a number of the other faculty members, and we have a number of graduate assistants and so on this. I'm not going to go through all of them. You can see them there, but they've all contributed tremendously to this project. This was one of the first projects that the Georgia had conducted. In fact, we received this award for a quick strike grant related to the special call for quality improvement quick strikes, and it was just a few months after we formed the Georgia PBRN, and so we got up and running right away with this. We were an affiliate member, not one of the core grant members. The practice-based research, this is about practice-based research in the Southeast, and I just wanted to mention a few things. We're heavily based on the Georgia health districts, which Georgia has 159 counties, and each has a county health board. But it's some of these counties are extremely small and very poorly resourced. Some of them are very large in the metropolitan Atlanta area, and our focus has been very much on a lot of the more rural, more poorly resourced health departments, and the districts play an exceptional role in regard to those, and so that's kind of how we got started. And of course, you know some of these ideas about what the purpose of PBRNs are, so I'll not spend much more time on that, but suffice it to say that these practices and principles of PBRN are very relevant to what we're trying to accomplish here in Georgia. Our initial project was how can the Georgia Public Health PBRN capacity build evidence to support health districts and the county health departments in an increasingly challenging physical and political environment, and particularly in light of the large number of county health departments and the very small populations that are in some of these counties and the very limited resources for the county health departments. So we were looking at the potential of the Georgia model of health districts to advance public health assurance and improvement, and also the role of these regional public health districts as a quality improvement collaborative for improving quality improvement for local health. And that concept of quality improvement collaboratives is something that is very well developed, and there are dozens and dozens of articles on quality improvement collaboratives for primary care. And in fact, the RWJ model is around quality improvement has been around this multi-collaborative, and we've had a number of meetings on quality improvement collaboratives looking at the broader public health, but we really haven't looked at kind of from a research perspective the role of quality improvements, particularly the role of quality improvement collaboratives as these regional bodies, these districts, or the term now multi-jurisdictional entities is coming up, or joint sharing entities, or there's different names that are emerging, but the concept is in many cases multiple jurisdictions have to kind of come together to be able to have enough resources to kind of meet the challenges of how public health is being defined and how local public health basically can fit within definitions of what a true fully functioning local health department is. So just to give you an idea, our PBRN started more in southeast Georgia. So that's the coastal area is down there on the lower right-hand side, and Atlanta, which of course most of you have probably, if you've traveled almost anywhere in the country, you've probably flown through Atlanta's airport. That's up there in those in that more north west central part of the state. So we started our PBRN more around where the Georgia Southern is, with the idea that the areas of the South Georgia tend to be much more underserved and much more poorly resourced than the more urban area around the metropolitan area of Atlanta. In fact, if you look at Georgia's rural counties, and that's defined legislatively as less than 35,000, these pink areas are all of the rural areas of rural counties of Georgia, and you can see that there's quite a few of those, and 35,000 obviously is a pretty small county. This map is showing those same the districts, and the districts are a key organizing structure. There's 18 districts in Georgia. They're kind of a hybrid between a state organization and a county organization, because the counties very much are involved. The district directors kind of coordinate county employees as well as state employees, so it's really very much a hybrid, and the county boards have a lot of influence over what goes on in the district. So it's really not purely a state model, and it's really not purely a county local government issue. It's a way of coordinating the counties and them coming together to share resources. This diagram here shows the how we involved in our first study 13 of the 18 health districts. So even though we started with one smaller part of Georgia, we rapidly expanded to include, and we've had very active participation then from most of the districts and most of the counties, 118 of the state's counties. So just to get into how our study was conducted, we adopted this quality improvement collaborative instrument, and we adapted it to public health and to Georgia. So the instrument was originally psychometrically tested with primary care. Some very important constructs and concepts about how a quality improvement organization functions are captured in this quality improvement collaborative instrument. So we thought that they would be very relevant to Georgia. So but it had to be then adapted to public health. So we had this expert panel of 11 of the 18 health district directors basically review this and to refine this instrument so it was public health oriented. And then we did a purposeful sampling was used to identify the key informants of the practice community. That's of the health districts that were participating in there. You can see we identified 269 key informants. And these included district office staff, they included local health department staff members, and they included Board of Health members. So that, to give you an idea of the sample of who the key informants were, recognizing that, again, within these counties, there are a lot of people that wouldn't know very much about public health, or certainly about essential public health services and those kind of things. So these were kind of key informants or leaders within the concept of kind of key opinion leaders. We used a survey monkey to actually collect the data from these key informants, and this was followed by reminder emails and then a series of 3 reminder phone calls. And as a result of that, we were able to get a 65% response rate, which was pretty good, because some of these people were recommended by or identified as key stakeholders, but we had to contact them and basically enlist them in the study. And so that was somewhat of a challenge, and we were pretty happy with that kind of a result. Some of the folks basically said they didn't know what quality improvement in public health was and had no interest in participating. So there are a number of things that were given that reasons for not participating, but we did get a pretty good participation rate, particularly for an online survey. Some of these online surveys are as low as 20% and so on. So, and this was not necessarily a highly motivated group like the district directors or something. So, kind of a different. It was a pretty good sample. What this is showing is the results of the expert panel, which basically shows that in regard to the review of the expert panels, there were 4 major constructs, and each of the items within the constructs, there were 50 items total, were rated by each of the expert panel members as to if it was applied to public health, if in fact the question was focused on public health based on the modifications that we did, and if it was relevant to Georgia. And the scores between 4 to 5 basically were Likert type scores of saying they either agreed or strongly agreed. So you can see that the scores were all above agree, between agree and strongly agree, and as a mean. And the Cronbach alphas showed pretty very, very great consistency then among the different expert panel members. Well, this is this is a comparison of then the original instrument, which is this Schouten primary care QIC, versus the Georgia district and our Cronbach alphas. And you can see here that actually this is of the 176 key informants that did respond. These Cronbach alphas were then calculated for each of the constructs. Again, those 4 constructs in the left-hand column. And you can see there that we had extremely high correlation or Cronbach alpha coefficients, much higher than Schauten's. And Schouten actually ended up, because of a factor analysis that they did, they ended up reducing it to 3 constructs, and their Cronbach alphas were not as high for those 3 items. So you can see that we actually were higher, and I'll explain a little bit more, then I'll get down to this, some of what the original research showed. This is a scree plot related to the factor analysis, and here what you see is 3 major items where most of the 3 major factors that loaded for a result of the factor analysis where the items loaded, showing that in effect there were 3 major factors or 3 major constructs within the 50 items. And what happened though with our particular assessment was that we ended up with essentially 1 item, and the 1 item related to the health districts as key facilitators of quality improvement. And so the point here is that we were very early in the application of quality improvement in Georgia. The qualitative data in particular kind of told us that there really wasn't very much quality improvement going on, and the district was the only place where that was even remotely feasible. So everything kind of was centered around the district. So whereas the original research was with established quality improvement collaboratives, we're looking at kind of baseline data of where things start, and so we kept all 4 of the constructs and that Schouten originally developed. So kind of an interesting result there. When we actually compared results, some of the questions that we had also compared how important the districts were to providing quality improvement, and essentially we compared a question that determined if the county could do it alone versus if the district and the county was needed. And this particular graph here shows the different kinds of responses depending on who the person was, what their position was. And what you see here is by kind of a 2-to-1 margin, pretty much consistently, regardless of if you're looking at boards of health or county health departments or district staff level, they all perceive that the districts were absolutely essential to being able to meet the essential services requirements to meet quality improvement requirements that were going to be associated with accreditation. That's kind of a really important message here is that local health departments, depending on where you were, at least from key informants' perspectives, the districts were pretty essential. Now, I just want to mention that this is an emerging issue and a challenge that's occurring throughout the country, and Georgia's districts are somewhat unique, this fairly unique hybrid. And they've been around for a while, so they're much more established. There isn't any resistance that we were aware of, although there were a few comments here and there in the qualitative reactions in some of these surveys to people being a little bit negative about the districts. But pretty much there was a very strong, obvious consensus that the districts and this regionalization of resources was critical in most of Georgia. And what's kind of interesting is that held up regardless of if we were looking at the populations above 35,000 or if we were looking at populations below 35,000. So, and then when we look at that a little bit more, if we, because obviously 35,000 isn't very big. It's big for Georgia, but obviously in the Atlanta area there are much larger populations, and even here we see more of a 2-to-1 kind of margin of where the districts were perceived to be critical for to be able to deliver the essential services. So an important message, I think. Well, we'll talk about that when we get to conclusions. We also looked at this in from a number of demographic viewpoints, but one of them was the county health department rankings, and so those counties that were in the bottom quartile versus those counties that were in some of the other quartiles and including the upper quartile. What we found was, regardless of where the county health department rankings were, where their health rankings were, they still were basically more in this range of a 2 to 1. Although if you look at the lowest rank, when it wasn't quite as it wasn't quite 2 to 1 as much as some of the others were, but you can see that there was still very broad consensus that the districts are critical to providing essential services. I do want to then get just a little bit into looking at these 4 major constructs that are in the upper row, and how different kinds of respondents then perceived of those. And what we see here is that, by and large, the scores for that varied. Many of them were more between the range of 3 to 4. Now, remember the validation study, the scores were between 4 and 5, but there they were simply measuring if it was relevant to Georgia. Here they were actually rating them in terms of their performance related to these 4 constructs. And here the range was more between 3, which would be in effect neutral, or 0, versus 4. So almost all the scores, with a few exceptions, were between 3 and 4, which means they were between 0 and they agree. So only a few of them even cross the threshold to agree, or being a little bit over agree. And so I just want to get across the idea that when it came to these scoring, people weren't scoring the districts highly in providing or scoring anyone as being high in providing quality improvement, and this reflects our qualitative information that said there wasn't a whole lot of quality improvement going on. But it's pretty critical, though, that if you're going to do quality improvement, it's going to have to come from the health districts. And here, this is when we're doing the correlations for all these different items to one another, individual item, I want to just draw your attention to one particular item, and that is, if we look at this 4.47. And we look at the other items, we see most of the other items are pretty highly correlated, with ranges between 0.5 and 0.7 in this graph, but actually some of them were 0.8 and 0.9 correlations. But if you look at 4.7 on the horizontal or on the vertical axis, you see very low correlations. And this is an interesting concept just from a science point of view in looking at this. Here, normally, this would be considered a real outlier, and in many cases you just throw it out because it's an outlier. But when you're looking at kind of complexity science, those outliers are considered fractals. They're considered the things that really make the difference. And so we kind of looked at this a little bit differently, and we're saying, okay, what's so different about this one that others were so highly correlated, this one wasn't? And here we see that competition between county health departments during the joint QI meetings was not rated. It was rated fairly low, and so, or very differently than how the others were correlated, in particular. And so what we have here is this item is a real anomaly, and I just want to get to the point that competition can be a very healthy thing if the emphasis on competition is to create all winners. If, on the other hand, you have winners and losers, or you even have a lot of losers, then that competition may not be so healthy. So most of the constructs, most of even the items were perceived kind of positively. This particular item was not at all similar to how the other items were rated. So it's kind of an interesting dimension of, if we're talking about quality improvement cultures and the culture of organizations and trying to study and create more effectiveness around that, understanding some of these dimensions may be very critical. And so just related to our conclusions, health districts are a basic infrastructure for local public health to deliver essential public health services in Georgia. The districts will need to have a major role in building local health department accreditation efforts in Georgia. The private and public sector support for building local public health infrastructure may need to recognize the potential for multi-jurisdictional entities as key elements for building local infrastructure capacity. And that's really important because a few years ago when CDC was, for instance, putting out grants, it was strictly limited to a single jurisdiction. You couldn't do multi-jurisdictions, and so it had to be a defined jurisdiction to be able to even apply for the grant. And as you know, the FAB, the accrediting board, has recently now included a separate accreditation category for multi-jurisdictional entities. So this is a fairly newly evolving concept, and so the importance here is that the PBRNs have a critical role in doing research around issues that are critical to public health. And so even though in this conclusion the qualitative responses indicated that Georgia's local public health systems have not systematically implemented quality improvement initiatives, but we did find this very important very important information around multi-jurisdictional entities and the critical role that these multi-jurisdictional entities in the form of health districts are going to have to play related to advancing quality improvement. And just a few other comments. This participatory approach of PBRN has the potential to support more grassroots agency support for QI and accreditation. We found, kind of with some of this, that there was a lot of negativity around accreditation and even around QI itself. But when it's done more from a district perspective, and the assurances are that this is district driven, the PBRN is practice driven, district driven, then there's much more support for moving forward with this kind of attempt. So that's kind of a critical issue about the practice-based research network. And again, then going back to this whole issue that the location of the PBRN and its association with the practice community is able to actually deal with some very timely issues. This issue of multi-jurisdictional entities and this concept of quality improvement collaboratives that really haven't been addressed in public health by and large in a significant way, particularly supported by the evidence or the research, is able to be advanced by the PBRNs. And so this type of research is a good example, I think, of how PBRN research can help to advance the field. And here's a few contacts, and this includes myself, and it also includes some of my affiliations that are in Florida also, and including the Duval County Health Department and the University of Florida College of Medicine, Jacksonville, and then also Angie Peden and one of Nandi Marshall, who's one of the co-PIs on our current research project. And that's pretty much it, and I'm happy to answer any questions that folks might have.
Fantastic. Thank you so much, Bill. Very, very interesting work. So I'm sure we have some questions from the field here. So why don't we just jump in? Try to just go ahead and verbalize your question if you have one, and we'll proceed ahead.
Hi, this is Dorothy Flente in North Carolina, and thanks so much. That was really interesting. I guess I want to better understand the role of the state office in Georgia, because in North Carolina we're a local system too, and we hear from our local health departments that the technical assistance and the infrastructure that the state office provides to counties is really important, both with accreditation success and quality improvement. I'm wondering if you're thinking this regional infrastructure might be similar to states that maybe have a local system but have a fairly sophisticated state resource to help in this regard.
Yeah, I mean, I know we had looked at North Carolina and saw that you do have a few districts for some of those areas where they have more rural kinds of things also, that's in the statutes and actually in practice there's a few, or at least one that's a district that has a multi-county district. And so I think and I might mention that in Florida, in Georgia, there's a couple counties that are single county, single districts, and there's a couple that are, a few districts that are just a couple county health boards. So the districts there are really critical. There is the Department of Public Health was just newly formed as a separate cabinet level position. So it used to be part of community health. It's just now, as of effective July 1st, as a separate department. I think that part of the state's health department's strategy for providing assistance is to do it partially through these districts. So they are providing this. Some of these employees that are in the districts are actually state employees, and many of them are also local county health employees. So it's truly a hybrid in that particular respect. These district directors are State Department of Health employees, but they are really located in the local area. They are somewhat accountable to the local boards of health, so they have to meet with those boards of health. So it really is much more, and so it's not so centered around the state support directly as the state agency, but the state basically is providing that support through through the district infrastructure. We have a few people on from Georgia. If anyone else wants to comment on that.
This is Gulzar, and I think that was a fairly good description.
Thank you, Gulzar.
Do we have other questions for the Georgia PBRN team? Well, maybe you could tell us a little bit about, Bill and colleagues, about some of your plans for next steps. I'm sure this is not the end point with regard to research around QI and around multi-jurisdictional approaches there in Georgia. So what kind of next steps do you have?
Thanks, Glenn. Yeah, I'm actually I'm anxious to share that. Obviously, I'm interrupting you to do that. Yeah, that's very important. This was partially establishing baseline data. That was one of the things, and so baseline, kind of assumes that we're going to be doing more work. In addition to and we did kind of deal with this issue of the districts having a critical role, and when we were forming the PBRN, we just got tremendous feedback that we had to work with the districts if we wanted to do anything. So it's kind of some of what we did with this study was from the insiders in Georgia. It's probably one of those duh moments. Everybody kind of knew that from that perspective, but establishing it and documenting it is another story. So we are now moving forward with, and again, this is with Robert Wood Johnson's support through that supplemental grant project, to expand the diversity of the researchers and to improve our quality improvement initiatives. What we're basically doing now is actually getting into intervention research with quality improvement, and doing it kind of as both kind of more of a developmental evaluation model, that concept of doing both evaluation but also providing technical assistance, so that you're helping to forward the progress of the organizational development. So we're basically moving forward with actually identifying quality improvement initiatives within the state, working with both the State Department of Public Health and also with the O. Stilt's office to actually build to help districts identify quality improvement initiatives. We have gone through kind of a nominal Delphi process to have them identify what were their top priorities. There's not an overwhelming consensus. Some of the areas that people want to work on are obviously accreditation, but not necessarily a lot. A number of other states are much more aggressively, I think, oriented towards accreditation. Georgia's has become more positive about accreditation than what it was even a year or so ago, but it's still not, embracing totally yet that concept, although I think the Department of Public Health is moving in that direction. So accreditation is one of the issues. There are several other issues. Electronic health information is another kind of critical issue that is certainly something that information exchange and electronic health records and those kinds of things, and interfacing public health with information exchange is becoming a critical national effort, and it's a challenge related to healthcare as well as for public health, and how public health and healthcare are going to be interfaced is an interesting challenge. That's something that the health districts have indicated that it should be a priority, and we have several other priorities. Well, we're probably going to be moving more towards a technical assistance, a model of actually using kind of an innovation diffusion model of where we work with those that are the early adopters and kind of move forward with an early adopter and then move to other levels of adoption with different folks as we kind of gain confidence, because I think it's a very common phenomenon within public health in general that folks are not looking for additional work to do right now. They are finding that their resources are declining. They are being overwhelmed with more and more demands, and they're not out there looking for more things. So doing this in a way so that we're working on where people are at, where they are with with those that are most interested up front, and then as people gain confidence that we're not imposing a lot more work, but we're simply helping them to work a little bit differently and doing it on their terms, then and researching that in the process is what our current efforts are right now.
Fantastic. Thank you so much, Bill. This is really exciting and important work. Certainly we know that there are, across our population of public health PBRN, there's a lot of interest in really both of these issues of learning what we can about quality improvement in public health and how to make it more effective, and also learning about the current and potential roles of multi-jurisdictional approaches to public health delivery and public health action. You're looking at the intersection of both of those very important issues here in Georgia, and we can learn a lot from what you're doing, but I think there's also a lot of opportunity for collaborative work across the PBRNs in these two areas as well. So thank you very much. We'll look forward to hearing more about this work as it continues to evolve, Bill and colleagues. And so
thank you, Glenn. And could I just put in one more plug? We're also on this more recent project. We're working with Bill Riley out of Minnesota, and he's actually helping us establish a very strong quality improvement presence out of Georgia Southern University to focus on public health quality improvement and build our training and education efforts, as well as all kinds of supporting infrastructure for public health quality improvement. So just wanted to mention that too. And thank you, Glenn, for all of your support. You certainly have been great in helping Georgia move forward in a kind of with a running start right from the beginning, and we really appreciate that.
Glenn, is there time for another question?
Of course. Go right ahead, Julie.
So this is Julie from Marshall from Colorado, and I was just interested. I don't know if I missed this, but a little more about how what's done at the district level and how much variation there is across the different districts, and what type of resources they share.
Well, the districts are somewhat autonomous because they have to be responsive to the county boards of health. So they do operate very differently. One of them up close to Atlanta is moving forward much more rapidly with quality assurance and accreditation, and they've been given some visibility around that. That is in no way the norm. So and some of the districts are, as I said, up in the metropolitan area around Atlanta, and about half of Georgia's population is up in that area. So that's very densely populated. And some of those districts are one county districts or double county districts. And whereas some of the other districts are more like 13 or even 16 counties in a district. So there's huge variety within the districts, and obviously the kinds of populations that you're serving, some are almost totally rural, and others might have, for instance, the coastal area has the urban area of Savannah and Brunswick and so on, and some rural areas, so they're kind of more of a hybrid of urban and rural. So you get there is a great deal of variety. They have and they deliver all kinds of different services. They're very individual. Their electronic information systems are all very different. There isn't a centralized Georgia health information system or data reporting system or finance system or any of those kinds of things. And I've done a lot of work in Florida, for instance, and continue to do a lot of work in Florida, and they have much more of a unified system for all these electronic information systems. And Georgia doesn't have that at all. So those are major challenges for Georgia. But to answer your question, they are very they select their own health information system. So they select what their priorities are. They select what their and they have to do it in concert with the local boards of health. So even within their district, they can have some variation.
Thank you.
Fantastic. Any other parting questions before we move on to the more mundane parts of our agenda for today? Fantastic. Well, you've got Bill's contact information and his colleagues as well there in Georgia, so don't hesitate to connect with the Georgia PBRN folks if you've got other questions or ideas around the research that's happening there in Georgia. So to move on to our kind of administrative component of the meeting this month, the first topic we wanted to talk a little bit about, we've been talking over the last couple of months about the upcoming PBRN annual grantee meeting that we're having again in conjunction with the Keeneland Conference. That is rapidly coming up. We've got about a month left before we will be able to get together in person in the beautiful springtime in Lexington, Kentucky, and to meet together in advance of the Keeneland Conference. So our agenda for our annual grantee meeting is shaping up. Again, we're meeting on the Monday and Tuesday morning of that week, April 16th and 17th, just prior to the main Keeneland Conference startup. We'll be meeting pretty much all day on Monday and then the half day on Tuesday with the main Keeneland Conference starting up there at midday on Tuesday. In terms of the agenda, again, I think we've Ann and some other members of our staff have Doris and others have been sending out information about the grantee meeting. What you see here is kind of the general flow of the day on Monday and Tuesday. We'll be meeting as a group from 8 to noon on Monday. We will have breakfast available, I think at 7 or 7:30 prior to that. So you can come down and get some breakfast, and then we'll try to get started around 8 o'clock on Monday. I know that's early for our West Coast friends, and I apologize. We try to make the most of our time together because we just so rarely are able to get together in person as a full program. So we'll have somewhat of an early start there. We'll break for lunch about noon, and we'll have a real break for lunch. We're not going to try to work over lunch, but we'll have lunch in a room together with some of the other ancillary meetings that are going on. So if you want to catch up with some of your colleagues who might be in for one of the other ancillary meetings, you can do that. We'll get back together for an afternoon session, a series of meetings as a program as grantees from 1 to 3:15, and then we will essentially break for the day in terms of our annual grantee meeting at about 3:15 because there's a larger RWJ meeting for a larger group of PHSSR grantees that will start at 3:30 that will run from 3:30 to 5 p.m. Kind of a networking event that involves not only our public health PBRN grantees, but grantees of some of the other public health services and systems research programs that the foundation funds. So that'll be a little bit of a break in the action, and we'll spend the end of that afternoon in that networking event with some of our other colleagues in the PHSSR community. For dinner on Monday night, we basically you'll be able to kind of self-organize into groups into dinner groups for that evening, depending on who you might want to go to dinner with, and depending on which of the many lovely restaurant choices that we've teed up for you you might be interested in. So if there's a group of your colleagues in the PBRN community that you want to group up with and go to dinner with, you can certainly do that on Monday night. Again, if you want to put together a group that includes some other, some of the other PHSSR people in your dinner plans, you can do that. We'll be able, at this networking event on Monday afternoon, we'll be able to kind of organize dinner groups for going out to dinner together on Monday night, and hopefully carrying on some of the networking and collaboration that may have been triggered during the day. On Monday night, I'll be breaking off on Monday night. I won't be going to dinner with you, unfortunately, but we also will be having our PBRN National Advisory Committee group in, and I'll be we'll be kicking off a meeting of that committee over dinner during the 6 to 8 p.m. slot. So I'll be getting together with our National Advisory Committee and picking their brains and tapping their expertise over dinner that Monday night. Then on Tuesday, we'll reconvene again. We'll have breakfast available at 7:30. We'll reconvene around 8 o'clock for kind of day 2 of our PBRN grantee meeting, and we'll meet up until about 11:30 in the morning, and we'll end at that stage because the main Keeneland conference events will be starting up shortly thereafter. In terms of topics and what we're putting on the agenda, again, we circulated some documentation and a draft agenda over the last couple of weeks, so you may have seen some of this already. Some of the discussion topics that we're planning for the meeting, certainly we'll be talking about strategies for growth and sustainability among public health PBRN. Many of our networks now have been up and running for 2 or 3 years or more at this stage. You're cycling through multiple funding awards, grant awards from the foundation. You're beginning to pursue funding from other kinds of sources, and so we want to have some time to talk about what you all are learning about growth and sustainability strategies, what we can learn from related activities and programs of the foundation and others going forward. So that's a major topic for our discussion. To tee up that discussion and to try to get a head start on that discussion, we're actually going to do a webinar this month to start to get some of those strategies on the table, and in advance of our Keeneland conference grantee meeting. So that webinar we have scheduled. Thank you, Dan. For next Friday, March 23rd, for those of you who are available to be a part of that. So 1 o'clock Eastern next Friday, we'll start this conversation about sustainability strategies and PBRNs, but we'll definitely have time to continue that discussion as well in person at the Keeneland conference. We're planning for an update from the FAST study, the Public Health Activities and Services Tracking Study that Betty Beckmeyer of the Washington PBRN has been leading, along with a number of our colleagues in the PBRN, Public Health PBRN program. We'll have a chance to give an update on that progress, that study, to give some more in-depth illustrations of the use of the data. We have a number of analytic activities that are now ongoing using those data, several spin-off studies and grants that the FAST study has already generated, so we'll have a chance to for folks to see some of that work in action, and also to talk about future studies and interests for doing future studies using these data. Again, this is a shared data resource that we're developing for public health PBRNs in the program, and we're starting to see the fruits of our labor pay off now in terms of data and analytic opportunities there. Third, we'll spend a little bit of time, like we've done in the past meeting, we spend a little bit of time talking about network analysis and using the tools of network analysis to help understand the growth and development of public health PBRNs. As we did with our round 1 networks, we over the last 6 months or so, back at the end of 2011, we repeated that network analysis survey with our round 2 networks and some of our affiliate networks. And so we'll be discussing some of the data from that most recent network analysis activity, talking about what we can learn from the application of network analysis to study the operations of your public health PBRNs, to study patterns of interaction within PBRNs and over time. So we'll have that on the agenda. Again, talking about issues of growth and scale, a number of networks in the program now are undertaking activities to grow the size and the diversity of practice settings that are participating in your network. We'll talk about some of the strategies being used there. Hear from some of our networks that are in a growth and expansion modes now. Talk about the whys and the hows of that. We also will have a chance to talk a little bit about the academic health department model and how that is beginning to fit into the work of some of our public health PBRNs around the country. The academic health department concept is a concept that's been around for more than a decade now, and has continued to evolve and grow over time. Several of the leaders within our public health PBRNs have been active in this academic health department model and are using that model as synergistically as part of their work in the public health PBRN. So we'll have a chance to talk about some of those strategies and opportunities during the meeting. We'll have some colleagues from the Public Health Foundation and from the Council on Linkages Between Academia and Public Health Practice who are playing leading roles in the academic health department movement now, who will be joining us for this section of our agenda to talk a bit about this topic. We've added to the agenda some time to talk about opportunities and models of collaboration between public health PBRNs and clinical PBRNs. We have some productive examples of collaboration in this area, and we want to spend a little bit of time talking about these types of collaboration and hearing from some of our colleagues in the networks who are who have some particular experience with these types of PBRN collaboration opportunities. That's also on our agenda. Did I hear a question emerging? Well, feel free to jump in if you have questions on any of these items. I think I've got a second page here. A few other topics that we have added to the agenda. We're going to spend some time talking about our dissemination strategies, dissemination and translation strategies, ways of getting your research findings from PBRN studies out to practice and policy communities, and how to facilitate the dissemination and utilization of your findings. Talking about some of the new vehicles we've developed, like the new Frontiers Journal, which will be launching the first issue of that journal at the Keeneland Conference, as well as the podcast series that we're developing as well. We'll be talking a little bit about opportunities for collaboration between PBRNs and public health institutes. I think we are planning to be joined for part of our agenda with some colleagues from the National Network of Public Health Institutes, NMPHI. Already several of our public health PBRNs have active involvement and engagement of public health institutes around the country, so we'll talk about some of those models and what some of the advantages might be of identifying productive collaborations with public health institutes in your state or region where they might exist. And then we also have planned some breakout discussion groups or work groups that we'll be engaging with during the course of the grantee meeting as well. a breakout discussion around the use of the FAST data from the FAST study. Secondly, we'll be having a breakout meeting for our PBRN networks who are going to be part of the new multi-network research opportunity, the multi-network practice and outcome variation study that will be starting up. This is the new research project that will be starting up in April next month. The 6 networks that were selected to be a part of that study. We'll be talking a little bit more about that here on this call in just a minute. But we are planning to have a kind of a breakout meeting to kick off that effort among the 6 networks that'll be part of that effort, and potentially other networks that perhaps are not receiving funding for Improve, but if there are other networks that want to join and be a part of this effort, we certainly would love to have you and can open up that breakout meeting to have you join us as well. A couple of other breakout topics that have been suggested by our members that we're planning for: a breakout work group on PBRN progress in developing quality measures of quality in public health practice. We're planning for a breakout work group related to research around the NACCHO model practices. This is something that NACCHO has a growing interest in, and several of our colleagues in our public health PBRNs have an interest in as well. So we'll do a breakout conversation on that. And then as well, a work group among some of our PBRN colleagues who are interested in studying health disparities and cultural competence issues in public health practice settings. So those are the major topics that at this stage are a part of our agenda. Again, these topics have in large part been driven by what you've told us you'd like to see and like to have on the agenda. You know, we're pretty far along in having the agenda developed and finalized at this stage, but again, if you've got other ideas or thoughts on these topics, don't hesitate to let us know, and shoot us an email to the Public Health PBRN account, and we'll be glad to be eager to incorporate your feedback into the final planning for our PBRN grantee meeting. Any questions or comments on the agenda so far for our grantee meeting? That's a lot of content we've got planned. We'll Anne assures me that we'll be able to actively manage that agenda and get through everything successfully. But obviously, we'll be doing a number of these discussions kind of through parallel tracks and breakout discussion groups to allow networks and people in the networks to kind of self-select into some of these topics that have particular salience for the work that's happening in your network.
Glenn, this is Scott Frank. Just wondering whether it might be worth it to consider a work group on PRCs and PBRNs. I know that there have been some issues with PRC funding, but there's certainly been discussion in the past about how to make those two public health organizations work effectively together. So I don't know how much interest there would be, but I know we'd have some interest in it here at Cleveland.
That's a great idea. And that is certainly something that we have talked about, and I know there is an interest in at least a subgroup of our networks in continuing to explore those issues. The other kind of collaborative opportunity that we talked about related to the PRCs is the CTSA awards that that some of our PBRNs are involved in institutions, and also a number of the PRCs are involved in as well. So, so that's a good idea. We can certainly, Scott, look at building in some time to talk about those collaborative opportunities as well. Other thoughts or questions at this stage on the agenda for the grantee meeting? Well, hopefully everybody at the stage has received information from us about logistics for the meeting, travel, registering for the conference, and making sure you have your travel taken care of. Again, we've got resources to support travel for a couple members of each network to attend the meeting, and you're welcome and encouraged to find ways of getting inviting other members of your network to attend as well. We, from our perspective, the more the merrier in terms of people who are part of your PBRN networks that might be able to join us for the grantee meeting and for the larger Keeneland conference. So if you've got, of course, if you have any questions or need any help with regard to logistics for arranging your travel or making sure you're registered, et cetera, don't hesitate to let us know, and we can help you work through that.
Glenn, there's only funding for 2 people to come? Is that?
That's correct. We've got funding in our budget to support travel for 2 people.
Okay.
From each network.
And is there any flexibility on from Boston to find a flight to Lexington under $500?
There's always flexibility. Yeah, we do not.
It is impossible. There's not one that exists. Even if we arrive at 3 in the morning.
Yeah, we don't want you to have to do anything heroic to Lexington under that $500.
That was last year's fun.
Yeah, I mean, Lexington is a smaller market for airfare. The fares are higher here, so if you need to, all we ask you if your flight's going to be more than 500, if you just let us know. Let Becky she's the person listed on the travel memo who's handling the travel logistics for us. Just let her know so that we can just, as we're keeping an eye on our travel budget, so that we'll know what to expect. But yeah, we certainly recognize that in a number of cases your airfare is going to be over that $500 limit, and that's just what it is. So, and please don't feel the need to fly to Timbuktu on your way to Lexington just to save a couple of bucks. I mean, we want to be respectful of your time and in getting here, so that we definitely have flexibility on that.
Great, thank you.
Anything else, Ann or Rachel or Dorothy, anything I didn't mention on it? Well, we're very, very excited about the grantee meeting. I wish we could do this more often than just once a year, but we definitely want to take advantage of our opportunity of being all together as a program in person to learn from each other and move forward on some of the exciting ventures together. Oh, yes. So Rachel is whispering in my ear. In terms of, this is Keeneland Conference registration. For the main Keeneland Conference, they did extend the registration deadline for the main Keeneland Conference meeting. So if you haven't registered yet, or if you've got colleagues who haven't registered yet, that deadline was extended. It was extended until tomorrow. So if you can help us get the word out, if you've got colleagues and others who are coming in for the meeting, registration is still available and is extended through tomorrow. And that's for the hotel rooms too, Ann tells me. So at the conference hotel and the conference rate. So make note of that. The main Keeneland Conference is also going to be an experience, I think, that you're not going to want to miss if it's at all possible. There are really some fantastic sessions that have been organized. A number of our public health PBRN colleagues are presenting your research as part of sessions at the main Keeneland Conference, as well as some really fantastic research being presented from our colleagues in the larger field. And we also have really some very exciting keynotes and plenary sessions that have been organized. Tom Frieden, who is the director of CDC, will be coming in and giving the keynote address on Wednesday afternoon, and we're obviously very excited about that, given all of the changes underway and all of the new initiatives underway at CDC. So that will be a session you won't want to miss. The keynote, the dinner, I think it's the evening keynote on Tuesday. Dr. Harvey Feinberg, the president of the Institute of Medicine, will be speaking. A brilliant person, obviously, and someone who, who's got a great mind for public health as well as healthcare delivery. His remarks, I think, are particularly timely because of two much anticipated Institute of Medicine reports that are going to be coming out just prior to the Keeneland Conference. The report on public health financing coming out of a committee that I've been serving on the last couple of years is finally going to see the light of day. And also a report, an IOM report that was commissioned by CDC and HRSA looking at the interface between primary care and public health delivery, also coming out in the next couple of weeks. Both those new IOM reports, I think Dr. Feinberg is going to be able to comment on that and on the larger issues of how science can help the nation navigate these health reform and public health system reform issues that we're in the midst of right now. Deborah Perez is giving the keynote and opening remarks, I think, at lunch on Tuesday. Carol Morley is also giving a keynote on Wednesday morning.
Hello? Hello?
I can't hear anything.
I just got back. I just heard your voice for the first time. I hadn't heard anything for a while.
Yeah, at 2:06, I lost audio from there. It sounds like we're on, but they're not.
Yeah, I had to reconnect, and so maybe that's what happened. Or did you all reconnect too?
I called back in, yes.
I called back in too.
Yeah. So we're talking to ourselves.
They must not realize it.
Yeah, I'm going to try and type them a message.
I just emailed, but I haven't been able to make the chat thing on this work. So, like I said, I did. Oh, there it is.
Well, that's Ann Kelly. She just sent an email or a chat room message that she's going to try and call back in. Do we have a lot of people on the line here?
This is Beth from Minnesota. We just called back in, so it sounds like that worked.
Yeah, same here. This is Janelle from Nebraska.
This is Betty at the University of Washington. I do think there's a lot of us on, but not the Kentucky folks.
Yeah,
and
still here too.
Yeah, well, Ann Kelly's the host, and she sent a chat reply saying she was going to try and call back in, so maybe they lost the phone line.
Hey, am I back?
Yes, you are.
Sorry about that. I just got kicked off somehow.
Yeah, we all did. We all had to call back in.
Oh, geez.
And then we were all sitting here talking to each other without your esteemed leadership.
Well, I'm sure that it was a productive conversation. I'm sorry about that. I didn't notice until I was just talking away and then happened to notice that in the chat box that everybody was saying, "Oh, we're kicked off." So I was describing some of the highlights from the Keeneland conference meeting, and I'll just leave it that it's going to be a very exciting meeting. So I hope, for everybody who's able to stay over, that you do that. It'll definitely be worthwhile. And of course, at the end of the session on Thursday, we'll all head over to the Keeneland racetrack to experience one of Lexington and Central Kentucky's greatest experiences, which is a real horse race. So I hope that as many of you who can will be able to join us for that. Any other questions just about Keeneland Conference stuff, grantee stuff that we didn't address? Well, again, don't hesitate to let us know if you've got ideas or concerns or problems or that we can help you with. In terms of the other agenda items, just briefly, as I mentioned earlier, I think I mentioned, hopefully before we got cut off, we do have a newly funded PBRN research activity that will be starting up next month, and that is the PBRN multi-network study, which we're calling IMPROVE, the multi-network practice and outcome variation study. That we had 6 public health PBRN applicants were selected to be a part of that study and to receive some additional funding from the Robert Wood Johnson Foundation to be a part of that study. The 6 networks, I can tell you, that were selected for this opportunity based on our external review process are Colorado, Washington, Minnesota, Florida, and then 2 new affiliate networks, Tennessee and New Jersey. Those were the 6 that were selected to receive funding on this opportunity. As I think I mentioned last time on the call, this was a really challenging decision process for our external review committee because the quality of all the proposals that were submitted were very high. And certainly, if we had more money, I think we could have funded all of the networks that applied here. Unfortunately, the foundation only has the funds to support 6 of the networks in this particular opportunity. But I tell you, our reviewers had a really challenging process, and in terms of the selection process here.
Glenn, could you name the 5 again?
I'm sorry, what's the question?
This is Betty. Could you name the 5 again? Washington, Colorado, Florida.
There's 6, and they are
6.
Washington, Colorado, Minnesota, Florida, Tennessee, and New Jersey.
Okay, thank you.
And so the award notifications have gone out from the foundation at this stage. Hopefully, those of you who received awards, hopefully you've gotten that, and hopefully I'm not telling you this for the first time. But certainly we congratulate the networks that were selected as part of this. we really thank all of you as networks who applied and thought through this process, because of again the quality of the proposals here was very, very impressive. We're excited about this opportunity. We are, as I mentioned, going to have a kind of a kickoff meeting for this study. As part of our grantee meeting, we'll have kind of a breakout group for the networks who are going to be part of the study to break out and do some initial planning and collaborative work together during the grantee meeting. I also have gotten questions from a couple of the networks who applied for this opportunity, but unfortunately weren't included among the 6 networks to receive funding. And the question is, if your network is interested in being a part of this effort, can you still participate? Can you still collaborate, even though you're not one of the 6 funded networks? And the answer is absolutely. We would certainly love to have, if there are additional networks that want to be part of this collaborative study, that want to participate in in implementing the measurement, development, and data collection activities that will be carried out jointly among the participating networks. If you've got other ways of implementing and being a part of the study, we'd love to have you join us as part of that. As we talked about, this study is very much designed to be synergistic with and an adjunct to the multi-network FAST study that Betty and others in the Washington network are leading. And very much we're trying to position this multi-network study to really complement the kinds of data, the kinds of measures, and the kinds of analytic activities that are already going on through the FAST study. So we're excited about getting this new project up and running. It'll be basically an 18-month project period that will start up in April, and so we'll make sure to keep everyone posted on the progress of that effort and what we're learning as that moves forward. We also had a couple of networks apply for an opportunity for funding a junior investigator from an underrepresented background to work on a mentored research project as part of your network. Our external review process selected 3 applicants to receive funding under that initiative. So we've got 3 of the networks will be receiving funding for a junior investigator to be a part of your work. Those networks are Washington, Missouri, and Ohio, as I recall. So, so congratulations to our networks who are part of that new opportunity, and thank you, networks who are stepping in to help us continue to build the pipeline of junior researchers in PHSSR and help us to expand the diversity of that pipeline as well. We'll send out more information about the projects that these new junior investigators will be working on in the coming weeks, just to get that out to our larger community of public health PBRNs. But we're very excited about those new initiatives as well. We still have the Quick Strike Research Fund opportunity that's out there. We've got I know several networks have submitted Quick Strike Research applications that we've had under review for a few weeks now. We hope to be able to get back with you very shortly for those of you who haven't heard back yet about the status of your Quick Strike applications. But in the meantime, we're still soliciting applications and ideas for Quick Strike studies. As your network has ideas for smaller scale studies of time-sensitive issues in public health practice and policy, make sure to keep the Quick Strike opportunity in mind. Some of these other funding opportunities that are listed here, this is actually kind of a copy from a list that we used a month or 2 ago. So this list is a little bit out of date. Some of these other funding opportunities have cycled on, but a couple just to mention. As we talked about last time, there is a new RWJ solicitation out to fund natural experiments in public health practice and public health systems. There was a letter of intent, or not a letter of intent, but just a requirement for applicants to submit their intent to apply that passed about a week or so ago. And so I know that a number of people in our public health PBRN community are intending to submit applications as part of that activity, and that indicated their intention to apply for that activity. So we're excited about that opportunity as well. If there's anything that we can do to help you, for those of you who are moving forward in developing applications for that natural experiments research opportunity, don't hesitate to let us know. That is another good opportunity for funding for research within the public health PBRNs. As I mentioned, some of these other items you see here on this slide are already out of date, but just a couple of others to keep in mind. There's also a new call for proposals that's out from the RWJ-funded public health law research program. So those of you who might be interested in that arena should take a look at that. I know just in the last couple of days, I saw from the foundation funding announcements from the foundation's HCFO initiative. That's the Changes in Healthcare Financing and Organization initiative. A bit more clinically focused research program, but obviously for those of you who are looking at issues that involve kind of the boundary of public health and healthcare delivery, public health and healthcare organization and financing, you might be interested in that particular HCFO funding opportunity from the foundation. There was also, I think just yesterday, a call that went out from the RWJ's, it was either the Active Living research program or their nutrition program, but there are, I'll nail that down and make sure to get that in the newsletter shortly, but there are a couple of other RWJ funding opportunities that have been issued just in this last week that are certainly relevant to public health and to public health oriented studies. Any questions on these either newly funded projects or funding opportunities that are coming up? If not, we can move ahead, and we're almost through. I know we just got a few more minutes here. Just to reiterate some of our dissemination opportunities. Thank you. Many of you, a number of our colleagues in the public health PBRN community submitted papers to be considered for the special issue of the Journal of Public Health Management and Practice that we are editing, that is devoted to advances in public health services and systems research. So those articles that came in over the last week or so are now out for peer review. Again, thanks to a number of you in the PBRN community who submitted for that. I think we're going to have just based on my quick read of the submissions, we're going to have a very interesting and robust set of studies to be a part of that journal. So you'd be looking to hear updates from the kind of peer review process as we move along there.
Glenn, can I ask a question about that?
Sure. Yeah.
Are the articles that we are reviewing, my understanding was that they were all conducted as PBRN projects. Is that not the case?
That is not the case. Yeah,
okay.
This is an issue that is devoted to to research happening in the PHSSR field broadly. So we've got
okay.
We have a solid cohort of papers that were submitted from related to public health PBRN work, but certainly that's not the entire universe of papers that are in the journal. So you
okay.
may many of you who submitted papers. This is a standard kind of policy of the journal. They also will ask you to review papers that to serve as a reviewer on other papers that have been submitted for this journal. So you might be asked to review a paper that is from a study that's outside the PBRN family of research, and that's just
Okay, so the special issue is not just dedicated to PBRNs, but public health services and systems research.
That's right. That's right.
Okay.
But we invited certainly a robust list of papers from our public health PBRN colleagues to be part of that. And I think pending the peer review process, obviously, I think the PBRN studies will be well represented in what we feature in this journal. So this journal issue. So,
that's helpful.
And certainly, thank you, Justine, and others who might be serving as peer reviewers as well for that paper. We're excited about that. In terms of other dissemination opportunities, I do want to mention again, we talked very briefly about this last month, but I wanted to mention again this new dissemination vehicle that we're developing with the Robert Johnson Foundation that I think is very, very exciting. We're developing a new electronic journal, an open access journal called Frontiers in Public Health Services and Systems Research. That we're officially launching next month in conjunction with the Keeneland Conference. We'll be unveiling the very first issue of this journal. It's designed not to replace the great journals that we already have, the great traditional journals in public health that we already have that publish our work in PHSR. But this journal is designed to do something a little bit different. It's designed to be more of a rapid cycle vehicle for getting early findings and preliminary findings into print on a much faster basis than is normally possible through traditional peer-reviewed journals. And it also, in terms of the manuscripts that are published through Frontiers, we're really targeting brief reports, short articles that highlight, again, preliminary and emerging findings from studies, and that really highlight the policy and practice implications of those studies. So these are our brief reports. We've modeled it in part after the MMWR journal that CDC publishes, the Morbidity and Mortality Weekly Report, that it publishes short features of epidemiologic research studies in that vehicle. So the Frontiers journal will be designed to kind of mimic that rapid cycle process and also mimic the ability to get early preliminary findings rapidly out into the hands of people who can use them in relatively short order. It is a peer-reviewed journal. We're publishing it through platform of Berkeley Electronic Press, BE Press, which is one of the now the kind of national and global leaders in open access journal publishing. It's going to be available free of charge. You don't have to pay money to submit as an author. You don't have to pay money to access these articles as a reader and a user. So we're also trying to eliminate the pay barrier that inhibits a lot of our colleagues, especially in public health practice, that inhibits them from being able to access the peer-reviewed literature in a timely basis because they lack access to an academic health sciences library and to the subscriptions for these pretty expensive journals. So there's going to be no financial barrier to Frontiers as well. So we want you to keep this in mind. Again, we'll be unveiling this journal officially next month at Keeneland with the first issue, and I thank a couple of our colleagues from the PBRN community who have submitted brief articles to be featured in this first issue. Again, this is a vehicle that's not dedicated solely to the PBRNs. We're accepting articles, contributions from anybody who's doing work broadly in the field of PHSSR. Certainly, we hope that those of you in the PBRNs will look to this vehicle as being a way of getting some early findings from your network out into the field quickly. We also have a partnership with the American Journal of Preventive Medicine that I think I mentioned last month as well, that will allow authors who publish in Frontiers can be invited to submit a full-blown scientific article from their study later, can be invited on a preferential basis to have that article published in the American Journal of Preventive Medicine in a subsequent issue of AJPM. So from an author perspective, this is a way of getting an early paper published and a brief report published in Frontiers and and then potentially later a full-blown scientific manuscript published in AJPM. AJPM will also be publishing every month a page of highlights from the most recent edition of Frontiers. And so, again, if you publish something in Frontiers, not only is it going to be disseminated through Frontiers, it's also going to be highlighted in the standard print and electronic version of the American Journal of Preventive Medicine. So this is going to be a platform that hopefully will allow your work to reach a much wider audience through Frontiers, through the highlight feature in AJPM, and then potentially down the road through a full-blown scientific article that you could publish in AJPM or some other platform if you wish. So we're very excited about that. Again, stay tuned for more details, and we'll be unveiling this at the Keeneland conference, and you'll be hearing a lot more about Frontiers in the coming months. And then also, again, just thank you to everyone who has done great work in submitting proposals for presentations and sessions and panels at the variety of meetings that are coming up later this year at Keeneland, at Academy Health, at NACHO, at APHA, at the American Society of Health Economists. Those are a few of the meetings that I know where we have public health PBRN presentations or panels that have been submitted. As you're starting to hear back from these meetings about acceptances, please let us know as well so we can add that to our to our calendar and keep track of, again, of the great work that you all are doing in terms of disseminating your work through conferences, through publications, and other vehicles. So I think that's about all that I have to say. I know we're just about out of time here, but I'll open it up if there are any other last-minute comments or questions or words of advice from our colleagues.
Glenn, this is Sarah from Colorado. When there was a schedule released earlier in the year about who was presenting at each of the meetings, we were slated to present in April.
Yeah. Thank you for mentioning that.
Not going to happen. Is there a new schedule?
Actually, I did it.
Yeah, Ann, why don't you come over and answer that?
I just sent a note to Lisa yesterday asking if you would like to present alongside another group in one of the upcoming months or to go to the end of the rotation for January 2013.
Okay. I'll talk to her. She's been out of town, so I'll figure it out.
Okay.
It's your choice. Yeah, sorry about that. We're not having a virtual meeting next month because we'll be together in Keeneland in person next month, and so we had originally slated Colorado to present some of their work in progress at our virtual meeting, but obviously since we're not having a call, we'll reschedule Colorado, either double up or find another date at the end of the schedule. So thank you, Sarah, for your flexibility on that, and we'll certainly look forward to hearing more about the great work of Colorado in subsequent meetings.
Okay, thank you.
Glenn, this is Laura Hitchcock. Can you hear me?
Hey, yes, Laura.
Yes, hi, from Washington. I just wanted to quickly mention that Betty and I are actually working with a doctor of nursing practice student who is going to be putting together a dissemination framework for us, and then we're also going to be, I think, working with another student who will look at deploying that dissemination framework. So it would be great if the student who we're working with now would have the ability to contact some of you to talk a little bit about what you're doing within your PBRN. So I just wanted to put that out there, and I can put an email out, I guess, to the group too, so you would know who would be contacting you, but I'm hoping there would be some interest in that.
Fantastic. That's great to hear. Wonderful. And we'd be glad to help you reach out or put a blurb in the newsletter or something like that if you'd like, Laura. Just let us know.
Okay. Yes, I'll be in touch then. Thank you.
Excellent. Well, thanks, everybody, for another great meeting, and we'll look forward to seeing everybody in a few short weeks in Keeneland. Again, let us know if we can help with anything, or if you've got ideas or insight or things that can help us. Don't hesitate to shoot us an email, give us a call, and we'll look forward to seeing everybody soon. So long.